Okay, so if I could have everyone's attention, we're going to move forward, and I'm going to welcome Dr. Peter Black. Dr. Black is a urologic oncologist at Vancouver General Hospital, and he treats primarily kidney, bladder, and prostate cancer. He also has a laboratory research program related to these urologic cancers. And we're also very privileged that Dr. Black also serves on our KCC Medical Advisory Board. Dr. Black's going to give us an overview of the current surgical treatments available for kidney cancer. So thank you and welcome, Dr. Black.
So good morning. It's great to see so many people out in force. I was told by Deb and Joan that we actually have more people than the first meeting in Toronto, so that's very important. We beat Ontario. That's good. So my job is to talk to you a little bit this morning about surgical management of kidney cancer, and I imagine there are a lot of people in the room who have been through at least part of this. And I don't want you to necessarily think that you had the wrong thing just because I'm presenting alternatives. There are a lot of nuances into what treatment each patient gets, so just bear with me as we move forward. So this is kind of my viewer rating here for the talk. I promise no blood and guts and gory pictures. Not allowed to show you any fancy videos. So it's kind of fun to look back at the history of kidney cancer. Fun, maybe from a surgeon's perspective, but there's been so much progress in the last 50 years that it's really quite rewarding. I'm a glass half full kind of guy, and we really have come a long way, even though there's still more to do. And I'm going to concentrate on some of the things on this bottom axis here, the evolution of the surgical management from big surgery to less invasive treatments. And surgery really is the mainstay of treatment for kidney cancer. Scott, as a medical oncologist, and you'll hear this afternoon from Christian Kohlmannsberger, obviously there are a lot of new drugs and very good drugs, so it's a combination of drugs and surgery, but surgery plays a big role in kidney cancer, and it plays a role in many different scenarios, which we're going to talk about. So the good old-fashioned operation for a patient with kidney cancer is what we call the radical nephrectomy. Radical just means we're removing the entire kidney, we're keeping a little bit of healthy tissue around the kidney, so the fat around the kidney, and classically we used to take the adrenal gland. We try to spare it when we can these days. And this is just a picture. Basically, we're just disconnecting the kidney from its blood supply and the ureter, which goes down to the bladder, and then we remove everything around the kidney. Scott touched on some of these things. When we have the kidney out, we send it to the pathologist, and the pathologist looks at it carefully and tells us exactly what is there. And this information is very important for deciding, on the one hand, the prognosis. So what is the likelihood of this coming back, or what is the likelihood that you're done, that's it, it's not going to come back? And then also for choosing next treatments. And Scott went over a little bit about stage and grade, so I won't repeat that. And then, of course, exactly what type of kidney cancer it is also very important. Kidney cancer is unusual in that we even do surgery in patients with advanced disease, so with metastatic disease. We know from older studies that patients will do better with the kidney removed, even if they have, for example, lung metastases. And so we continue to do that today. It doesn't necessarily mean that we're trying to cure the cancer, but we are trying to improve the overall quality of life and duration of life. So classically, the nephrectomy, the radical nephrectomy, has been performed in an open fashion through an incision in the flank. I'm sure there are a few people in the audience who have scars they could proudly show. And this just shows you a little bit how we put the patient on the side, and we go between the ribs or off the tip of the ribs, and it leaves a scar that can be variably long. If you had your surgery a long time ago, it's probably longer than the scar would be today. But we still do some open nephrectomies. They can't all be done laparoscopically, but laparoscopic is the alternative. Laparoscopic surgery is where you have several small holes with a camera, and the instruments go through the small holes, and you can manipulate the kidney and dissect it out. And then usually you have one larger hole in this patient down just above the pubic bone, where you actually remove the kidney. We like to remove it in one piece so the pathologist can look at it and tell us exactly how extensive the cancer is. This, of course, is a young lady, so she needs her incision down there so she can still wear her bikini. So as I mentioned, not every patient is suitable for the laparoscopic surgery, so if you have a big incision, there might have been a good reason for that, and we might still do it that way in 2013. For example, patients with bad lung disease, we can't inflate the abdomen with CO2 to do the surgery because we wouldn't tolerate it. And there are other things as well, the tumor characteristics especially. So if there are a lot of lymph nodes, we can do that better open, or if the tumor is just very extensive. So we certainly still do some open surgery. One of the new things out there, and I don't want any of you to go to your doctor and ask them to do this for you, but one of the new things that some people are doing, really just individual people in centers of excellence, are doing what we call single port laparoscopy. So instead of 3 or 4 small holes, there's only one hole. And you can see that they have this special device where you actually put multiple instruments through this port, which goes in just above the belly button. The scar is supposed to be there somewhere. And this is supposed to show you how the instrument works. It's actually, so your left hand goes in and crosses over to the other side, and your right hand does the same. And it is extraordinarily difficult to be looking at something on the left if it's actually your right hand, and vice versa. So there's a lot of work to be done here, but it is exciting to see the push of technology as we try newer things. Natural orifice surgery is called NOTES, is also sort of sexy new technology, as we like to say. And the idea is to really get down to 0 holes that anybody's going to see and use the natural holes. And this may seem a little strange to you, but this, for example, is removing the kidney through the vagina. This is removing the gallbladder through the stomach and the colon. And this, of course, just requires specialized instrumentation and an awful lot of patience. Patience, not you patients, but... So one of the issues with removing the entire kidney is, of course, the question is, is one kidney enough? Is if you have a kidney removed, will you have enough function to avoid dialysis or other health problems? And the answer is usually yes. I mean, most patients will be fine with one kidney. Doesn't mean immediate dialysis. But we do know that even if you're fine for however many years afterwards, that there is potentially decline over time, and some patients will end up on dialysis. We also know that although you may not notice the difference on a day-to-day basis, that decrease in kidney function that happens with removal of one kidney can lead to a higher risk of other diseases, especially cardiovascular disease. So in recognizing this, we've really come to the conclusion that we should be trying to save kidneys as often as possible. And let me just define kidney function for you. I don't think Scott had this, but I hope I'm not repeating him. But the way we define kidney function is, on the one hand, the creatinine, which is a blood test. And this is actually measuring the substance in the blood. And then we often talk about another number, the estimated GFR, or glomerular filtration rate. And it's a little bit more exact because it takes the creatinine and then calculates, based on your age, your gender, and your body weight, a better reflection of your true kidney function. And the serum creatinine high is bad, the eGFR high is good. So it's always a little bit confusing in that regard. And it just so happens that the normal for the eGFR is about 100. And that's really normal for a 20-year-old maybe. As you get older, that number does go down. But it makes it kind of easy to think of your kidney function as a percentage of that 100. So if your eGFR is 60, you think you have 60%. If it's 30, you have 30%. So this eGFR is a number that is good to understand, and it's something that we go by. And so in general, if we remove a kidney, so dialysis will happen in a range of 10 or 15 on the eGFR. So that's very low. And a lot of patients, after having a kidney out, may have an eGFR of 30 or 40. And they're not going to notice that. But we do know that an eGFR of less than 60 will increase the risk of other disease, and therefore we want to preserve as much renal function as possible. I'll just let you take in that for a second. And this leads us to partial nephrectomy. So there's been a big push over the last 10 years or so for partial nephrectomy. This is where we just remove the tumor. You can see the small ball here, and a little thin rim of normal kidney around the tumor, but we leave really most of a healthy kidney behind. And the idea is you preserve as much kidney function as possible, and even if you lost the other kidney for any reason, this kidney would probably be enough to keep going without dialysis. There are again different ways of doing a partial nephrectomy. So in the mid-80s, early 80s, mid-80s, it was a brand new surgery, and it was always done open. And then in the mid-90s, we started with laparoscopic surgery, and now we're often doing robotic surgery. But however you do it, it's the same operation. You remove the tumor and sew up the defect and save the kidney. Robotic is the newest way to go. There aren't that many robots in Canada. We use the robot mostly for prostate surgery, and it's not proven to be any better than the other techniques. It's just an alternative. And then this, of course, is also heading the same direction of the single port surgery that I talked about, where you only have one hole, one working port. And here the advantage of the robot is the robot will actually correct this right-left shift that I was talking about, so that it'll trick your brain into thinking you're actually doing what you think you're doing. So partial nephrectomy we will always try to do if we grade the indications absolute, relative, and elective. So we have to try it in a patient who only has one kidney. So there we will always try and save the kidney if technically feasible. Of course, patients with tumors in both kidneys, we need to save one or the other or both. And then patients with severe kidney problems already, we want to save as much function as possible. And then there are the relative indications. These are patients that have something that already threatens the kidneys, even though their function's okay right now. And then we'll also usually try for the partial nephrectomy. And it may be stone disease, something like diabetes that puts your kidney function at risk, or some of the genetic syndromes that Scott talked about. Initially, in the 80s and early 90s, this idea came up that you could actually do it electively. So you don't need to have any kidney damage. Just if your other kidney is perfectly healthy, you can still do a partial nephrectomy. And this was thought to be very radical thinking. And at the meetings, people who suggested it were booed off the stage. And of course, now it's standard of care. Any tumor that is really can technically be removed by partial nephrectomy, it should be considered, especially those less than 4 centimeters and increasingly those less than 7 centimeters. This is just a bit of a graph from the Cleveland Clinic. They are the ones who really started partial nephrectomy trend. And you can see how well patients do. So 5-year cancer-specific survival for tumors less than 4 centimeters is 96%. And as you get bigger than 4 centimeters, obviously it's a more significant cancer and this higher likelihood of having it spread somewhere. But patients do very well if you can preserve the kidney. So the problem is that even though there's good evidence that partial nephrectomy is optimal treatment for small renal masses, very few surgeons are actually doing it. So there's still a preponderance of radical nephrectomies done in the US and Canada and UK and other places where this has been documented. More and more partial nephrectomies are being done, but it's still at a much lower rate than you would expect. And it's partially because it is technically more difficult and the complication rates are potentially higher. So how much of an issue is this? Well, this, by the way, is a small renal mass on the upper pole of this left kidney here. It is a big issue because most of today's renal masses are in fact these small ones. And as Scott highlighted, we used to diagnose kidney cancer based on a palpable lump and blood in the urine and pain in the flank. But now most of these tumors are diagnosed by an ultrasound or CT scan done for another reason. You come into the emergency room with the bellyache and you're automatically stuck in the scanner, and then you have a 2.5 centimeter renal mass. So it is important to try and to treat these without taking out too many kidneys. The other thing is a lot of these kidneys will be, not a lot of these kidneys, but some of these tumors will be benign, depending on the size. If we take less than 3 centimeters as a cutoff, somewhere around 25% of them will be benign. And some of the others are very likely not to grow. So only about half of them will be the regular kidney cancer that we would expect to grow very much. So one question is if partial nephrectomy is already potentially better than removing the whole kidney, but the question is always, is there anything that we can do that's even less invasive than an open or a laparoscopic surgery required to remove the kidney tumor? And these are especially important alternatives for patients who are older, who have other medical problems. Some patients, of course, refuse surgery. And so there are 2 technologies that we are now doing. One is cryoablation, which is a freezing of kidney tumors. And you can see here on the left, there are 3 thin probes that have been placed into this kidney tumor, and then a generator basically lowers the temperature, and then it's allowed to thaw, and then it freezes again, and this freeze-thaw cycles will actually kill the tumor cells. You can also do it here, as shown laparoscopically. So this is an ultrasound device that we've put in laparoscopically, and there's a probe in the tumor, and you can watch it. This is supposed to be showing you the ice ball, which can be visualized on ultrasound, so you know how extensive your freezing has been. And there's, I would say, limited experience with this, so it's not a tried and true treatment such as partial nephrectomy or radical nephrectomy, but there are centers, for example, at Cleveland Clinic again, where there are a lot of patients who've had it, and they tend to do quite well. The rate of recurrence in the kidney is higher. It's very safe. There are few complications. The alternative is heating, so freezing or heating. Radiofrequency ablation is the heating, where you stick these prongs into the tumor. This is not a CT scan. You can see it going in through the skin at the back into a tumor here, and then you turn up the temperature, and it goes up to around 50 degrees or above 50 degrees. And this melts the tumor to some degree. It denatures the proteins, and the tumor dies. And again, it's much like cryoablation, where there are single institutions who've done it in a fair number of patients, but it's not quite as established as the other surgical options. And there are occasional complications, and you have to be careful how you do it. If the tumor is right next to the collecting system of the kidney, for example, you'll get scarring and potential blockage of the kidney, which is a big problem. This shows an example. So this is the tumor here, sort of in the front of the kidney with the liver next door. This is a probe in it, cooking it, and then this is a year later. You still see something there. It doesn't just go away. There will always be something there, but there's no viable tumor left. So in general, we keep these treatments either for patients on trial, patients unfit for surgery, or patients who just don't want surgery. Now, the push towards less and less. I started with radical nephrectomy, partial nephrectomy, and then the percutaneous ablations. Of course, the next step is to actually do nothing, so active surveillance. And this comes back to the point I made that a lot of these tumors don't actually grow very much, or some are even benign. And although we're diagnosing a lot more kidney cancer, and we are treating it more, we're not seeing a decrease in the death rate. And that would imply that a lot of these tumors don't need to be treated, that patients are destined to die of something else, to die with the kidney tumor but not of the kidney tumor. And this is also shown in autopsy rates. So if you find a kidney tumor at autopsy, the idea is that it wasn't really important, it's just found incidentally, and so those rates are going down, yet the death rate from kidney cancer is not. So we're probably over-treating these small masses. And we know that the very small tumors are very unlikely to metastasize. So we are able to watch them without really having to worry about metastasis. coming back to Cleveland again, one of the largest single institutional series here is 110 patients. They were all over 75, these patients, so there's a very select group of older patients who may have been at higher risk for intervention, and they were watched, and the bottom line is that they all did very well. Interestingly, 43% of the tumors did not grow at all, and those that did grow grew about half a centimeter a year. Nobody died of kidney cancer of these 110. And there was a trial done in Canada. Michael Jewett in Toronto led a trial where we collected data on patients, and that hasn't been reported yet, but it was a very good experience with active surveillance also in Canada. Problems are, of course, there's always an element of uncertainty. And we can't be certain that every tumor is going to take this fairly benign course. Some tumors may be a little bit more aggressive, and that's why we save it really for the oldest or the sickest patients. The data out there is still in relatively low numbers, and we don't have good ideas of how exactly to decide when to intervene. So a lot of unanswered questions. How do we follow ultrasound, CT, how often? When do we pull the plug? Is it after 3 centimeters, 4 centimeters, 5 centimeters that we need to intervene? Can we do this in the 50-year-old, or does it have to be somebody who's over 75? Biopsy is a big issue. I haven't put biopsy in my talk at all, but we're doing more and more biopsies of small renal masses to actually figure out what they are before we make the treatment decision. And then when do we intervene? So in summary, radical nephrectomy is still considered to some degree the gold standard, but is often overkill, over-treatment. We still do it in open fashion for advanced disease, laparoscopic for more localized disease. Partial nephrectomy has really replaced radical as the gold standard for tumors less than 4 centimeters for sure, and in a lot of cases less than 7 centimeters, and there are multiple ways of doing it. Radiofrequency ablation and cryoablation are considered experimental or investigational, and are suitable for those patients who have a reason not to undergo surgery. And then active surveillance is something that we are still studying and is likely safe in a certain selection of the patient population. And that is it. Thank you.